For busy clinicians, what are one or two programmatic tools or programs they can maybe use to systemically integrate things like exercise, posture training, and smoking cessation for axial spondyloarthritis care? Any thoughts?
Yeah, I actually don't have any thoughts on that one. We could probably skip that.
Okay. Please.
Tools, yeah, I'm not really quite sure. I mean, I guess it really just be
Yeah.
dependent on what's available to in the physician's area. But yeah, we could skip that one.
Yeah. Cool. Let's talk about comorbidities. How do you practice How do you practically risk stratify and monitor for extra musculoskeletal manifestations like uveitis, IBD, and psoriasis in patients primarily presenting with axial symptoms?
Right. So, at each visit that we do see patients, we do take a thorough review of systems just to make sure they're not developing anything new, in the spondylarthropathy realm, but just also as a human being, because patients aren't like an autoimmune spine walking to me, but they're like an entire human being, So we do ask at every visit, is there any eye pain, eye redness, difficulty seeing, any new onset diarrhea, abdominal pain, blood in the stool, any new rashes. And if any of these questions are positive, then we would refer them to the appropriate specialist, whether an ophthalmologist or a gastroenterologist or a dermatologist. But hopefully, the medicines that they're on should also be treating their skin as well.
Mm. Cardiometabolic conditions are a major driver of outcomes in inflammatory arthritis. What should every rheumatologist be doing to screen for and address cardiovascular risk, specifically in spondyloarthritis?
Yeah, that's a great question, and sometimes it's just overlooked a lot. A lot of times, autoimmune diseases, the one of the leading causes of comorbidity or mortality really is cardiovascular disease, right? People die from atherosclerotic heart disease. So we do want to check the cholesterol, the low density lipoprotein, ensure that we have a hemoglobin A1C also, just to kind of, check also for diabetes and to have these in an appropriate range. Knowing that inflammation, these underlying rheumatologic diseases, they themselves are risk enhancers. So a lot of times we associate obesity or a family history, but we should also bear in mind that autoimmune diseases or the inflammatory, arthritis are risk enhancers for developing atherosclerotic disease. So I would agree with totally checking, these markers at baseline, but then also, again, there's that holistic approach. So talking about diet as early as you can in with meeting the patient, talking about exercise as early on in the visits as possible with the patient.
Mhm. When you have a patient with overlapping, say, fibromyalgia or chronic pain syndromes, how do you avoid overtreating with immunomodulators while still respecting their symptom burden?
Right, that's such a great question. I think this is where physical exam comes in handy if we're finding any particularly swollen joints or tender joints, particularly swollen joints. That's very helpful. And then an MRI would also be helpful too, because an MRI will show us if there's active inflammation going on in the spine, and that oftentimes helps us to know what to do with the immunosuppressants.